welcome back from Baltimore. It's my pleasure and honor to welcome Bill Brady this morning. Bill Brady is a professor of emergency medicine and medicine at the University of Virginia. He trained first in internal medicine, followed by emergency medicine, and then was chief resident. He's held innumerable positions at the University of Virginia Medical Center, including chair of the resuscitation committee, co-chair of the airway committee. He's medical director of rapid response unit and several EMS agencies. He's lectured locally, regionally, nationally, internationally. He's been a mentor of mine, has won numerous awards, including the ACEP National Teaching Fellowship Award. It's my pleasure to introduce him, and he'll be discussing one of my favorite topics, electrocardiography, as well as his vast interest in acute coronary syndrome and cardiac arrest resuscitation. So welcome, Dr. Brady.
Well, thank you so much for the very kind introduction and also for the invitation to speak with this amazing group of educators. Very excited to be here and talk about, as stated, an important topic for all of us. So good day to everyone. Looking at the map, it's good morning to some, good afternoon to others, and good evening to the others. So thank you for attending. And without further ado, let's get started. So we're going to talk about errors in ECG interpretation and the implications on risk management and, of course, civil litigation and that sort of thing. Stated another way, how are we going to avoid the medical legal landmine in the emergency department when it relates to ECG interpretation? So we're going to talk a bit about that. Now, usually, MI presents typically. Okay, the diagnosis is pretty straightforward. Someone comes in with chest pain, they have a concerning physical exam, their electrocardiogram is abnormal, if not diagnostic, and appropriate treatment and disposition follows. So not a challenge really for the emergency physician. But unfortunately, it's not always that simple, okay? And in fact, MI is missed roughly in about 1 to 2% of cases currently in the United States, okay? These challenges, these issues that do make it more of a difficult diagnosis include the so-called atypical presentation. Some people use the word non-traditional, and of course, difficult to diagnose. This is probably about 30% of all MIs where there's some atypical, non-traditional, or challenging feature. Certainly the older person presenting with confusion or some other non-chest pain complaint. We know that after age 80, usually people with acute myocardial infarction present with something other than chest pain as the predominant issue. We can certainly see people at any age presenting with dyspnea with or without acute respiratory failure. Their preoccupation with not being able to breathe distracts them from chest pain, whether they're having it or not. Of course, there's been a lot of literature that very appropriately focuses on the female patient presenting with non-specific symptoms somewhat earlier in the progression to acute MI. And then, of course, what we're going to talk about today, non-diagnostic confounding ECG presentations, among many others. And of course, we also need to mention serum marker issues, whether they're normal, abnormal, non-diagnostic, etc. So a range of issues out there that can hinder or get in the way of our diagnosing acute MI in the emergency department. Now, there's a lot of older literature that says, wow, MI is missed 25% of the time in the emergency department. Those studies are really not appropriate for the emergency department. They have issues with methodology. They have issues with conclusions. They just have issues. A more appropriate study that is now 22 years old was published in the New England Journal, and a large multi-center investigation that really found that somewhere on the order of about 2% of MIs are unintentionally released from the emergency department. In other words, the diagnosis wasn't made, or if you're a plaintiff's attorney, the diagnosis was missed. A similar rate for unstable angina. And factors associated with unrecognized ACS included female gender, younger age, non-white race, atypical pain presentation, and a normal or non-diagnostic ECG on presentation. Not surprisingly, these patients that didn't have their MI diagnosed on presentation had higher rates of poor outcome and higher rates of litigation. Now, a more contemporary study that is still a bit old is based on a 2007 database review of several large state-based and national-based databases. And they noted a 0.9% rate of missed myocardial infarction. Factors associated with higher rates of unrecognized MI in this case included younger age and Black race. Factors that were associated with lower rates of unrecognized MI included larger hospitals, teaching hospitals, active cath labs, et cetera, et cetera. So these are really the two largest studies in what we would consider semi-contemporary literature. And again, a 0.9% missed rate of MI. Now, when we look at the medical literature, specifically focusing on litigation against emergency physicians and other emergency practitioners, there's a pretty robust literature out there. Multiple papers per year in a range of journals, medically based, emergency medicine based, and of course, legal medical publications. And when we boil this down, we see that cardiovascular syndromes represent anywhere from 19 to 37% of all such claims made against emergency physicians. Common themes for the so-called alleged issue here focus on undiagnosed MI as one of the more common issues, inappropriate treatment of MI, even though it was diagnosed, cardiac arrest resulting from whatever cause, incorrect treatment of a dysrhythmia, and then also the so-called findings or diagnosis not considered. That really is a list of the common themes from the medically based medical legal literature. When we look at the legal literature and look at, for example, the most frequent incorrect diagnosis in patients that were ultimately found to have an MI, musculoskeletal represents almost half, followed by GI issues, which really shouldn't surprise us. And then the so-called atypical chest pain, whatever that is. And then some people are actually diagnosed with stable angina that apparently wasn't or progressed on to more serious forms of coronary issues, including ACS. Now, when we look at the primary issue or problem in these missed MI cases, we see that incorrect test interpretation and over-reliance on a negative test almost always directly impacted the electrocardiogram. Of course, serum markers were represented in this group as well. But incorrect discharge means you didn't really make the diagnosis or interpreted studies perhaps in an incorrect fashion, error in diagnosis, and of course, failure to order the test, didn't obtain an electrocardiogram, didn't order serum markers, okay? So when errors in ECG interpretation occur, multiple different issues can happen. It can lead to the wrong diagnosis and a mistreatment opportunity, okay? It can lead to the wrong diagnosis and incorrect therapy. Oh, and of course, you can use the findings from the ECG in an incorrect fashion. So several different ways we can run afoul of doing the right thing with the electrocardiogram. And we're going to highlight three cases today that are common themes in cases that have gone to litigation. STEMI mimic versus STEMI, non-diagnostic electrocardiograms, and of course, our good friend, the left bundle branch block pattern and acute myocardial infarction. So let's start with case number one, okay? But it was benign early repolarization, wasn't it? There's a 58-year-old female presenting with chest pain, mid-sternal, aching feeling and pressure, radiation to the left shoulder. On exam, she's alert and oriented, but she's pale, anxious, and diaphoretic. So a concerning physical exam and a somewhat concerning description of the discomfort in a patient that certainly is of the appropriate age to be at higher risk for ACS, acute MI, et cetera. The electrocardiogram obtained within a couple minutes of ED presentation, as shown here, was immediately read by the emergency physician. The emergency physician interpreted this as sinus rhythm with concave ST elevation, likely benign early repolarization, and the physician also noted no reciprocal changes. What do you think? We'll come back to it. So about 2 hours later, the patient had just been taken from the waiting room and placed in a treatment room. The ECG was repeated, showing pretty significant progression. Certainly ST elevation in leads V2, V3, and the beginnings in V4, V5, along with some T-wave abnormalities in lead 3. Unfortunately, minutes after the emergency physician saw this second electrocardiogram, the patient developed cardiac arrest with ventricular fibrillation. Aggressive prompt resuscitation was provided, and unfortunately, she did not live. She died about an hour and a half after being placed in the room. Autopsy showed near complete LAD occlusion with findings consistent with an early evolving anterior wall infarction. So looking at the initial electrocardiogram and of course the subsequent one after the fact, reading the ECG, I certainly agree with sinus rhythm. I do believe there is ST elevation, which the physician noted in V1 to V3, but I don't believe it's consistent with early repolarization. I think it's consistent with an early ST elevation myocardial infarction. The statement that no reciprocal change is present, I agree with, but that is largely meaningless in this case. So let's go through the ECG interpretation issues, and there's really three that must be highlighted here. First of all, benign early repolarization. Secondly, the contour of the ST segment itself, and then of course, reciprocal change. And then we'll close out this case with clinical correlation. It's always important to read the test, in this case, the electrocardiogram, within the context of that patient from which the ECG was just obtained. That makes a huge difference. So first of all, what is benign early repolarization? Benign early repolarization is a benign variant. It's a benign form of ST elevation that really has no clinical significance other than it can be misdiagnosed as pericarditis. It can be misdiagnosed as acute MI. It can be misdiagnosed as a number of different entities. Now, we typically see this in the precordial leads, V1 through V4. Then the next most common pattern is precordial and limb leads. Important take-home point here, it is very rare to solely be present in leads 2, 3, and AVF, okay? Other important point here, it's usually seen in younger patients, male patients, and African-American patients, okay? It is uncommon in older patients, and the literature suggests that age 50 is about the cutoff point, okay? It is very common. It is very typical when you see this to see it in people in their late teenage years, their 20s, 30s, and then the pattern itself will gradually lessen and quite literally resolve, quote unquote, by the late 40s, age 50. It is highly unusual to have it persist beyond age 50. You can see this in female patients, but it's more common in males. And you can see this in any patient of any ethnic background, but for reasons that aren't known, it's more common in African-American patients. And what is it electrocardiographically? It's ST segment elevation. Basically, the insert here shows an awesome classic textbook picture of early repolarization. The ST segment is elevated. The J point, which remember stands for juncture between Kuros complex and ST segment, is elevated. And the key feature here is that the upsloping portion of the ST segment is concave. It really, frankly, to me, looks like somebody reached down, grabbed the ST segment, and pulled it up off the baseline with preservation of this concave contour here. You can also sometimes have large T waves. When we look at the cause of ST elevation in the emergency department, chest pain patient, we see that benign early repolarization represents about 10 to 15% of people that we are evaluating for potential acute myocardial infarction. So it is not a rare pattern. It is not uncommon. It is something that you will see probably weekly, maybe not daily, but probably weekly if you work several shifts a week. Now, that's a nice segue into the next issue to discuss in this case, ST segment contour. Comparing early repolarization on the left to STEMI on the right, we see really three different ST segment waveforms: the concave waveform, the convex waveform, and the obliquely straight waveform. Now, any waveform can present for any reason. Classically, the concave waveform is associated with non-acute myocardial infarction presentations, while convex and obliquely straight are very suggestive of STEMI. A study that we did at the University of Virginia now about 20 years ago looks strictly at the morphology or contour of the elevated ST segment in patients that met the AHA definition for STEMI based on the electrocardiogram. And we found that a concave presentation was very, very often not associated with STEMI, while either a convex or obliquely straight waveform was very frequently associated with STEMI. But please note that I did not say concave equals non-MI and non-concave, meaning convex or obliquely straight, equals MI. That is not the case. There are definitely examples of situations where you can see concavity, particularly early in the setting of STEMI. And Steve Smith, who's done a lot of very good ECG research aimed at the emergency patient, has really looked into this and noted that early, particularly in anterior wall myocardial infarction, you can have initial concavity. And here's a patient over about 45 minutes progressing from really non-specific findings to more progressive ST elevation, large T wave. And really the first 5 electrocardiograms all demonstrate some degree of concavity of the elevated ST segment. It doesn't really become obliquely straight and more quote unquote classic for STEMI until about 45 minutes into the event. So waveform analysis, looking at the contour of the elevated ST segment, is helpful, but it is not black and white. It is not 100% foolproof. Concave suggests non-MI and non-concave suggests MI, but there are exceptions. And then the last ECG issue to talk about is reciprocal ST depression, also called reciprocal change. Reciprocal change is your friend because it can help you make the diagnosis of MI. But first of all, what is it? It's defined as ST depression on an electrocardiogram that also has ST elevation, okay? When we see reciprocal ST depression or reciprocal change, we have a very high degree of certainty with a positive predictive value in excess of 95% that ST elevation is in fact a STEMI. So this is a very specific finding that allows us to rule in cases. And in situations where the ST segment elevation is minimal or of an unusual contour, or there's something else electrocardiographically that is making the diagnosis a bit more difficult, the presence of reciprocal change gives us a fair amount of certainty that we actually have a STEMI. It also is an identifier of patients that are more ill, okay? It identifies higher risk STEMI patients. Now, important take-home message here. In addition to this identifying a patient with a high likelihood of STEMI, we also unfortunately don't see it in all STEMIs. We see it in about 3/4 of inferior STEMIs and about 1/3 of anterior STEMIs. So if it's there, it helps you. But like many things in medicine, if it's not there, you can't rule out the issue. And in this case, you can't rule out STEMI. So those are the 3 ECG issues in this case where the problem, from which the problem arose. But the other is clinical correlation, okay? And there's 2 points there. First of all, the patient was ill appearing, pale, anxious, and diaphoretic. And that certainly doesn't sound like a benign presentation, right? The other is this is not a typical patient who has early repolarization, primarily the age, okay? She's 58. And remember, by the age of 50, early repolarization has largely resolved and is no longer present electrocardiographically. This is a pattern we see in the 20s, 30s, and 40s, but it is gone by age 50 in most people. So the likelihood of this being early repolarization, strictly based on the patient's age, is much less likely. So 3 points to stress here. Benign early repolarization rarely, if ever, occurs in older patients. Sorry, with older defined as greater than age 50. Remember that STEMI can present with concave ST elevation, particularly early in the course, and reciprocal change is not always present in STEMI. If it's there, it helps you. If it's not there, it doesn't help you. Okay, so this case is styled on multiple different cases over the last 20 years where these issues were encountered that largely led to a missed diagnosis and or mistreatment opportunity. Now, moving on to case number 2, but the ECG was normal, right? Here we have a 65-year-old female, chest pain, aching substernal pain with diaphoresis now resolved, so the patient's pain-free. She has a history of diabetes, hypertension, elevated cholesterol, and a past MI with known coronary disease. She is alert and oriented. Her exam is unremarkable. The electrocardiogram is here and larger version. The ECG was interpreted as normal sinus rhythm with no STEMI. I largely agree with that. Okay, I don't see a STEMI, and this is sinus rhythm. Patient was evaluated with 2 troponins, both negative, standard sensitivity. The provider also calculated a heart score and came up with a value of 3. The patient was discharged to home after 6 hours and instructed to follow up with primary care doctor as needed. Returned to the ED later that day, chest pain, active, nausea, vomiting, diaphoretic, a very ill-appearing patient. Electrocardiogram shows ST segment elevation in the lateral leads, consistent with STEMI, and also the suggestion of a posterior wall MI with some ST depression in the anterior leads. Patient was rapidly transferred to the cath lab for PCI, and while they were preparing to access the artery, developed VF. She was resuscitated promptly and received a stent to the proximal circumflex artery, but was unable to return to work post-MI. So normal sinus rhythm, yes, I agree. Left axis deviation, that doesn't have a whole lot of impact and bearing on what we're going to do in the first hour or so of a chest pain patient. But this electrocardiogram demonstrates non-specific ST wave changes. And so exactly what are non-specific ST wave changes, aside from a mouthful of words, okay? Despite the name being non-specific, it's actually a specific category of ECG interpretation. That's sort of the transition between a normal electrocardiogram and an obviously abnormal, if not diagnostically abnormal electrocardiogram. And it's defined as ST deviation, so either elevation or depression less than a millimeter, or T waves that are not normal and not obviously inverted or hyperacute. So the blunted T wave, the flattened T wave, some people even include the biphasic T wave in this definition. Important take-home message here is that non-specific ST T wave abnormalities does not equal a normal electrocardiogram. And here is a list of older literature. There's not a whole lot of contemporary literature that has looked at this, but looked at a series of patients presenting with chest pain and diagnosed with acute MI within 24 hours of ED presentation. And this is the percent on the right of people that had the first electrocardiogram categorized as non-specifically abnormal, not normal and not diagnostically abnormal, but kind of that minimally abnormal transition zone. Okay, first ED ECG, anywhere from 4% to a very large 21%. This point is a bit aberrant, okay? not suggesting anything other than it's pretty high up there compared to the rest that range from about 4 to 8%. Okay. So when we look at patients that have presented to the ED and are diagnosed with MI within 24 hours of ED presentation, remember the vast majority of these are admitted to the hospital, we see that somewhere on the order of 4 to 21% will have these nonspecific changes. Remember that up to 50% of people that have MI ultimately diagnosed in the ED had a non-diagnostic ECG on presentation and later evolved into an more abnormal pattern. Okay. Later could be 10 minutes, could be 3 hours, it could be early the next day. Now, it's very important to remember that the electrocardiogram, while a massively awesome test, does have its limitations, and it's a single electrical snapshot in time of what the heart is doing at this instant in time. Okay. And while it can be predictive in certain situations of what might happen later, it is still just an electrical picture of the heart right now. So we need to read it with this limitation in mind, and we need to read it within the context of the patient's presentation. That's incredibly important. Now, I hadn't mentioned this yet, but I do want to mention it because the clinician used the heart score here to aid in decision making. Now, remember the heart score, a reasonable test. There's literature out there that suggests it's reasonable. There's literature out there that questions it. You know, it's a reasonable way to help formulate your thinking, but it doesn't think for you. It's a diagnostic aid. You still have to do the thinking. Okay. And if you use it correctly. Okay. Your definition of the 5 variables may not be consistent with what the developers defined. You must use their definitions to correctly use the test. We're not going to go through the definitions, but here's the heart score. The clinician caring for this patient had a calculated score of 3. When I go back and look at it, of course, after the fact, Monday morning quarterbacking, all that sort of thing, I come up with a score of 7. Okay. I have a score of 3 because not only was this a very specific history for ACS, the patient does have a history of MI. So I gave the patient a higher score. ECG, 0, non-specific, does not equate with any higher number, and age of 2, risk factor burden 2. Okay, this history should actually be a 2 here. So we have a score of 6. Remember, a score of 3 or less identifies somebody that might be appropriate to go home with follow-up, while a score of 4 identifies a group of people that might benefit from more extensive evaluation at that ED time. So first of all, with this case, nonspecific is not normal. Nonspecific is just that. It's a nonspecific finding. You have to read that within the context of the patient before your eyes. Okay. Remember that a patient with a nonspecifically abnormal electrocardiogram can ultimately be diagnosed with MI. Consider the clinical context. Look at your patient. What is the patient doing? How is the patient acting? And if you use a clinical decision rule, make sure you understand the definitions of the variables and calculate it correctly. Because if you use it as an aid and you use it incorrectly, you're going to end up with some potential problems. And let's move on to the last case, case number 3. But the ECG was scarbosa negative. So here we have a 61-year-old female with chest pain, just like my past heart attack. She has a history of coronary disease with MI and an ejection fraction of 30% from chronic heart failure. On exam, she was anxious appearing and somewhat pale. Troponin number 1 obtained within about 2 to 3 hours of chest pain was negative. Electrocardiogram shows a left bundle branch block in the setting of sinus rhythm, and no ECG evidence of acute MI was the interpretation by the provider. What do you think? I agree with that. I think that's the correct interpretation. The patient was admitted to the hospitalist. Cardiology was consulted. It was late in the evening, and so cardiology was not contacted and saw the patient at 7 a.m. the next day. Patient had ongoing chest pain during the evening. Second troponin was markedly positive around the time the cardiologist was seeing the patient, who took the patient to cath pretty quickly. She had a near complete LAD occlusion with significant myocardial infarction, and her ejection fraction was found to be about 10% 45 days after the MI. So the interpretation is, yes, I agree with it. Sinus rhythm with left bundle branch block and appropriate discordant ST segments with no ECG evidence of MI. But does this rule out MI? And the answer is, of course, no. We know that left bundle branch block pattern in the setting of MI diagnosis is a real pain in the rear end. Okay, first of all, it confounds the ECG diagnosis of MI. The altered depolarization patterns typical of a left bundle change the repolarization findings and actually reduce the ECG's ability to demonstrate ischemia and infarction. And in fact, even though we don't know this number conclusively, it's theorized that roughly 80% of left bundle MIs will not demonstrate abnormality other than just the left bundle. In addition, we know that left bundle branch block is a common mimicker of STEMI. For physicians and other clinicians that aren't comfortable with reading the ECG, they see ST segment and T wave changes that are repolarization abnormalities of left bundle and assume they are ACS related. Okay. We do know also that left bundle branch block, whether it's a pre-existing block or a new block, is a high-risk feature. People that have acute MI in the setting of left bundle have much lower resultant ejection fractions if they are not treated appropriately, aggressively, and in timely fashion, as we saw in our case. They also are at increased risk of acute cardiovascular problems like third-degree heart block, VTAC, VFib, cardiogenic shock, and probably the most severe complication being dead. Okay. Remember, roughly 80% of left bundle MIs are not detected by the electrocardiogram. So it's important to understand what the anticipated ST segment and T wave configurations are of a left bundle so that you can recognize anticipated and therefore recognize unanticipated and potentially abnormal. I refer to this as the concept or rule of appropriate discordance, which means that the major portion of the QRS and the ST segment should be on opposite sides of the baseline. On the left, we have discordant ST elevation, and on the right, we have discordant ST segment depression. This is what we would expect to see in an uncomplicated left bundle branch block pattern. Here's a 12-lead electrocardiogram showing these findings, again, in leads with entirely or mostly positive QRS complexes, you should have ST depression, and in leads with negatively oriented QRS complexes, you should have ST elevation. Now, it's important to be able to recognize these anticipated findings in left bundle so that you can recognize the unanticipated, potentially MI-related changes seen in some people with left bundle. Here is the modified Scarbosa criteria, initially reported in the late 1990s by Dr. Scarbosa and colleagues, and then modified by Dr. Steve Smith, an emergency physician. This really is the contemporary rule. It is definitely worth being very comfortable with and applying. And really, there are three findings of significance. Concordant ST elevation, meaning that the ST segment is elevated on the same side of the baseline as the major terminal portion of the QRS complex. In the original and subsequent Scarbosa investigations, in the appropriate patient with the correct clinical presentation, concordant ST elevation was strongly suggestive of the presence of acute MI. Here is an example of concordant ST elevation in leads V5, V6. Remember, with a positively oriented QRS complex, we should have ST depression. Another important point about any of the three Scarbosa criteria, you only need to have one lead with abnormality. Okay, it's not the typical two leads in the same anatomic distribution. If you have one lead with abnormality in the correct patient, you have an ECG that indicates acute myocardial infarction. The second finding is concordant ST depression, limited to leads V1 through V6, where the ST segment is depressed on the same side of the baseline as the major portion of the QRS complex. Interestingly, in most of the Scarbosa studies, the polarity or direction of the T wave has not found to be important. Here's an example of concordant ST depression that is somewhat subtle in appearance in lead V2. Right? This is all you need to demonstrate that acute myocardial infarction is present. Remember, based on this negative QRS complex, we should anticipate some degree of ST elevation. Also note the T wave is upright, and that can further make this diagnosis of concordant depression challenging. And then the modification produced or developed by Dr. Smith and colleagues that was very important. The original Scarbosa criteria had a third criterion of excessive discordant ST elevation greater than 5 millimeters. That was weakly associated with the ECG diagnosis of acute MI. And the main issue there was that the ST segment elevation was not addressed in a proportional fashion to the QRS complex. Remember, in nature, things are usually proportional. So if you have a larger negatively oriented QRS complex, proportionally, you should have more ST elevation, and vice versa. So Dr. Smith came up with a ratio that compares the magnitude of the ST elevation to the magnitude of the amplitude of the negative part of the QRS complex. So ST elevation relative to the Q wave or the S wave, whatever the negative component is. And if that's greater than or equal to 25%, that is strongly suggestive of acute MI as well. Okay, strongly suggestive. Again, you only need to have it present in one lead. Here's an example Dr. Smith provided for our learning pleasure of a patient presenting with chest pain. I'll point out that by the old Scarbosa criterion of greater than 5 millimeters of discordant elevation, this ECG would be negative for acute MI. And in fact, when we compare proportionality in V2 and or V3, we see that the ST segment relative to the negative part of the QRS complex is greater than 25%. And in a patient that has a good story for acute MI or ACS, you have ECG evidence of acute MI. Remember that it is normal to have discordant elevation here, but we have too much elevation relative to the size of the QRS complex. Herein lies the importance of the modification to the Scarbosa criteria, addressing this proportionality issue of how much ST segment elevation that's discordant is acceptable or appropriate. So very important to grasp this idea. Now, when we look at the left bundle patient and we're evaluating them for ACS or acute MI, we use the three traditional approaches: the history of the exam, the electrocardiogram, and the serum troponin. But unfortunately, the ECG is significantly invalidated, not entirely, but significantly. So keep that in mind when you're evaluating your patient. So take-home points here regarding left bundle MI patients are that these are diagnostically and therapeutically challenging patients. Okay, they are not easy. They are difficult patients to manage. They are difficult diagnoses to make, and they have a lot to lose. Recognize what you should see in a typical left bundle regarding the ST segment and T waves. Okay. And when you recognize what you should see and understand the modified Scarbosa criteria, it will enable you to recognize what you shouldn't see. And in the appropriate patient with chest pain, looking and acting like an acute myocardial infarction, you can rule in electrocardiographically the presence of acute MI. But please remember, don't make the mistake that this clinician did, that if the patient's Scarbosa negative, they're not having an MI. More left bundle MI patients will present with just a left bundle, okay, compared to a left bundle with modified scorbosa abnormality. Now, we as emergency physicians and other emergency healthcare providers must be experts in ECG interpretation. And from the emergency physician perspective, there is literature out there to say that we are. Correct interpretation and correct application of this interpretation allow for the correct diagnosis and treatment of our patients, and of course, the best opportunity for optimal outcome for the patient. So that is that. Hopefully you learned a bit here or reinforced some practice points. Thank you for attending, and everyone have a good day.
Dr. Brady, that was a great talk, and I had certainly learned a lot. There's a few questions that came up. One listener was saying that their cardiologists at their facility don't recognize the entity of unstable angina, and even if there's intermittent chest pain or classical MI symptoms at rest and they're not resolving, but if the EKG and troponin are negative, they recommend sending the patient home. And he's wondering if you know if this is validated by any literature, or are the cardiologists making a risky decision there?
Yeah, so that's the tough call. So the patient that has a normal electrocardiogram and negative markers and yet still has a very concerning story, you know, certainly the emergency physician is on the hot seat. I think watching the patient a bit longer and having a short-term follow-up is not an unreasonable issue. Let's use the heart score here. Let's use it correctly. And if we do have a score of 3 or less in someone that has undergone some degree of monitoring in the ED, and you've talked to a cardiologist, that person is probably safe to go home with short-term follow-up. Remember, the heart score identifies a group of people that have a very low short-term outcome, but use it correctly, calculate it correctly so that you can order your thoughts and can assist you appropriately. I'm faced with that. I worked yesterday and had a patient not unlike that. I had a heart score of 3. I was concerned about the story, but the ECG initially and subsequently was negative, and I actually did 3 troponins. I kept the patient around for 8 hours and ultimately was sent home. So fingers crossed. I think I did the right thing. And just sometimes, you know, this is not an absolute science. Okay, we got to do the best we can. Let's document appropriately and move on and learn from each of our patient encounters.
True. The other question came up is, when we're doing the heart score, why is the T or troponin even included? Because a lot of people, not many, would discharge patients with positive troponins. Any comments on that?
Yeah, well, I think first of all, you'd have to ask the original developers why they included it, but it does make sense because it is a component of the evaluation, and it actually almost begs the question: do you have to get troponins in everybody with chest pain? Absolutely not. Use your clinical decision making. Use your gut feeling. If you're concerned about the possibility of acute myocardial infarction, obtain a troponin. Absolutely. If you don't feel they're at risk of ACS or MI, and you don't feel that what you're dealing with is acute myocardial infarction or something leading up to it, don't get a troponin. And if you're not worried about ACS, then you're not going to use the heart score in general because you're not worried about acute MI. Okay. I think it is valid to include the troponin. And if you actually play around with the numbers, it is really difficult to come up with a markedly abnormal troponin and no other abnormality in the patient evaluation. Yes, you could come up with some stylized score that gives you a score of 2 with a very abnormal troponin and everything else is 0. But in reality, I have never seen that, and I have not heard of other people seeing that. But again, remember, the heart score doesn't tell you what to do. The heart score assists in your decision making. And if you have a situation where you have a heart score of 2 or 3, you've used it correctly, and you're still really very much worried about the patient, move on and continue to evaluate and advocate for your patient.
What about the in the same setting of CKD, a patient who always has positive troponins or like a baseline troponin? Would you consider those to be dischargeable? I guess with those baseline troponins.
So yeah, if you have the luxury of past data, and remember, whenever you compare a current value to a past value, make sure you understand the setting in which that past value was obtained. We always assume that that baseline value was a nice, normal, stable patient, but let's make sure they weren't having an acute MI when that last value was obtained and you're using your comparison to a baseline inappropriately. I think in those patients, they're at higher risk. We see them all the time. And I think that you need to do the correct thing for your patient, use your judgment, factor in several troponins, trend them over time. Our haste to get people in and out of the ED, sometimes we don't need to do that. Let's do 3 troponins over 3 hours each. If you use high sensitivity troponin, that can help you shorten the time frame. But sometimes just watching people for a longer period of time is totally appropriate and totally correct. Trend the troponin, and if you have a positive slope, a trend that's positive, you've got something else going on, whether it's ACS or some other physiologic insult to the heart producing a troponin elevation.
Makes sense. Well, in the interest of time, I'm going to stop the questions here. I will send you the questions so you can answer them, and I can post them on the chat.